Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me, as always, Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital, and thankfully also a pharmacist, so he gets all the technical questions with regards to vaccines, medication interactions, so forth. We'll be giving you our usual weekly update with regards to status of COVID-19 in our community, update on current numbers, statistics, vaccine, testing, what we see happening trend-wise, probably the most interesting thing over the course of the past few weeks or so, and then what we see as far as projections, and then maybe a global reflection, just to really make it interesting. So starting out with numbers, about 5,500 positives, but really the numbers that we go back to is all about the number of positives. So the all positives around 6.7%, and then the unique positives somewhere around 25. And that unique number is really always the one that floats to the top when we talk about things, because there are so many people that are getting tested repeatedly because of either repeated exposures or because of work, things like that. So that unique number is the one that we really respect the most to say what our positivity rate is. And really things have been a hotbed of activity the last month or so, but the trend a week or so ago was we got a little bit of relief, but we're seeing some numbers kind of come back up again.
Yeah, and to be expected, there's going to be an ebb and flow. We're still in a state of sustained transmission. We've used that terminology a few times throughout talking about this. So while percentages can go up and down a little bit, we're still seeing that it's within our community. There can be outbreaks. There's that sustained transmission. And while we've seen some hospitalizations go down, a little bit of break there, we did note that the number of positive cases on a daily basis over the last week has been hovering in that 19 to 25 range. Yesterday's case report for positive cases was 77. So it's not a relax, COVID is gone, and certainly take a look outside the windows and you see weather kind of starting to shift a little bit. Things may move more indoors. We know from a risk assessment scenario that's when transmission can be higher, so masking, distance, monitoring self-symptoms is certainly going to continue to be really paramount as we move forward to keep this trend, where it's at. We had a state call this week and looking at some of the modeling and forecasting that we talk about, because as we get more data, we're able to start to try to look ahead. And our District 10, which is Southwest Indiana Hospitals, has seen a decline that is about a week to 10 days earlier than maybe what was predicted, but the other 9 health districts in our state have not seen the same decrease. And when you look at the counties, there's still a lot of red around the state, which means the risk of transmission, and that could easily pop back up, because just 2 weeks ago we had the unenviable designation as the highest number of positive cases, the highest positivity rate. So things can change pretty dramatically one way or the other. So happy to see that level of decrease, and certainly have felt that in the hospital. Has been some reprieve for our staff to be able to see some of those numbers go down, but we're continuing to watch that very closely.
And really, if we go back a couple of months when we were talking about the Delta variant in Missouri and other places around the world, what we expected or were hopeful of was it was going to be a sharp spike up and a sharp spike down. And as you alluded to, we were a little earlier than other places in the state. And so hopefully if we are on that backside, that's something that we can take some solace in, that things are improving. One of the interesting things that we talked about before we started today was what population is getting this and the age range. And certainly we've seen that shift a little bit to the younger population. We're certainly seeing it a bit more in our adolescent population, our 20s and 30s up to early 50s and 60s. But that has shifted, and it's shifted into a population, thankfully, that we're a little less worried about in terms of severe illness. But the focus still is getting people vaccinated to prevent severe illness, hospitalizations, ICU admissions, intubation, and that population still remains our high-risk patients.
Absolutely. So that 20 to 60-year-old population, 65% of our positive cases over the last few months have been in that group, our adult workforce group, if you will. But as you mentioned, certainly the risk factors as compared to the older than 60 population are much less now, as long as chronic diseases are being managed, and certainly there's risk within those groups, and that really reflects more of what we've seen from a hospitalization standpoint, but that puts emphasis on vaccination and doing your homework on the vaccines, keeping up with the most current data. There's more and more data coming in all the time, but it all carries the same theme, and that is that the vaccines are safe and effective and astronomically safer than a COVID infection.
Yep.
And just some of the stats that we see with that are myocarditis has been mentioned in the younger population getting vaccinated. And I know there's been a lot of concerns with that. And certainly when we're talking about the heart, you get very concerned.
Yeah.
I mean, that's natural. But the risk of myocarditis with a COVID infection is 16 to 18 times higher than that associated with vaccination. So it's that's the world that we live in the medical world, is risk benefit and what's the safest path forward, and certainly we're seeing that. And then severe anaphylactic, which are the severe allergic reactions, can't breathe, those types of scenarios that get associated with all kinds of drugs. Mm-hmm. But with vaccines in particular, we have seen the mRNA, Pfizer and Moderna data that has came out. Nothing against Johnson & Johnson, just hasn't been reported. But the mRNA data has been reported, and it is 2 to 3 times less occurrence of anaphylactic reaction than other vaccines that have been around decades. And so the safety profile, the efficacy profile with Moderna reporting 93% prevention in hospitalizations against Delta, Pfizer reporting 88%, are just showing overwhelmingly that these are safe and effective and really our path forward.
Yeah, and that's something that sometimes gets sort of muddled is the side effects of these vaccines. But you and I have talked about this since the inception, that really probably when we look forward to what most vaccines will be in the future, most of them are probably going to be mRNA technology, purely because we have seen such a lower rate of those side effects, injection site reactions, anaphylactic reactions, other systemic consequences. And it's just because of the methodology by which this is made. And so really we will predict that likely in the future the majority of all new vaccines coming out will be of similar type technology. Now that population that we're talking about, we've discussed in weeks past what's been happening with monoclonal antibody. We were early as far as administration of that within our state, have continued to administer a lot of that, getting people from Illinois, from here within Indiana, and even within a 3 or 4 state area coming in to get that administered. That population still remains individuals that are higher risk, meaning they have other comorbidities and such. Things were getting a little lean last week in terms of supply of monoclonal antibody. As I understand it from our pharmacy, things have been replenished. We're looking better on those numbers now.
Yeah, and so, following on the heels of President Biden's announcement of the path out of the pandemic, part of that included monoclonal antibody discussion and a ramping up of supply. Well, as with anything, when you start to make changes to ramp up supply, there was a hitch in that, as it was controlled at more of a state level than federal level. Well, that lasted less than a week, and now we've kind of went back to the ordering process. So that supply chain is now solidified. We feel comfortable with that, and as you mentioned, it's been a great tool in keeping patients out of the hospital. We've given over 1,000 administrations, and we've seen greater than 97% of those patients stay out of the hospital. And when you look at that, what the number that you need to compare that to is, as you mentioned, eligibility criteria. These are high-risk individuals. They're looking at 35-40% of the time being hospitalized. So we're talking, under 30 individuals being hospitalized out of over 1,000 to what would have been 300 plus. And with hospital resources where they are, I can't imagine a scenario where we're talking about 270 plus more hospitalizations over the course of that year, and the pressure that would have put on the hospital with those patients staying on average 10, 12 days. It would have been, unfortunately, crisis standards that we've had to talk about, that we've been able to stay kind of below that threshold. So good news is that seems to be a mechanism that ordering, we're able to get that in. We've been able to treat a very wide network of patients from Illinois, Indiana, even outside our normal service area. And I think more hospitals are getting on board with that. And I do believe that from the government standpoint, that push for increasing up to twofold the amount of monoclonal antibody available is starting to happen.
Yeah, and we've been fortunate because we got into this early and we're administering that early. So we've had a lot of experience with it. The process is easier, but it's still very important that those individuals that are at risk get identified early on. We have seen the biggest and most amazing turnarounds in patients that are in those first few days of illness. So day 1, 2, 3, 4, 5, the further along in the illness that they get, the less effective the monoclonal antibody therapy has been. Roughly about day 7 to 10 is when we start saying this is probably not going to be as beneficial. So individuals who have symptoms, individuals who test positive, individuals who have risk factors, and those risk factors can be as simple as high blood pressure, being obese, diabetes, common illnesses that many of our patient population have. It's important to recognize those symptoms early and get tested. Testing is readily available now, so it's not difficult to get tested and determine if you're positive. And if you're positive, you have risk factors, we want to get you set up for that as quickly as possible. There's a variety of ways to get plugged into that system. As you mentioned, we're having a lot of outside providers from outside of our community call Dr. Mahan or myself, get that approved. But also within our system, it's even more efficient to get that done.
Right. And it starts with that testing. And so when we talk about our convenient care sites at Williams Brothers on Washington or out of Willow Plaza or at our medical center of Vincennes on the back side of our largest primary care base, it starts with positive test, then assessment by a provider, and seeing a provider and being assessed is a key element in this discussion. And it's not just positive tests means I can show up at the hospital and get monoclonal antibody, but you have to be assessed to make sure that the risks are from a patient standpoint that have risk factors that would make you eligible for receiving monoclonal antibody. But as we look at testing, we've moved to a online scheduling-based test, and that has worked exceptionally well for helping to control the volume on a smooth hour-by-hour basis. It doesn't limit volume, and often you hear schedule and think, well, that's going to limit volume. We haven't limited volume. We've just smoothed that out to control it so that our staff can take care of patients timely and not say, hey, you showed up, come back in 5 hours. Now you can go online, you can look at the schedule. Through our website, you can access that through where you click on our convenient care or call out to the convenient cares, but they're not going to schedule you over their phone. They're going to give you guidance on, okay, here's where to go and schedule either through MyChart or through our website.
Sure. And as we move forward, the population that we are treating with that is pretty broad, ranging from the pediatric population, adolescent population that has received that for some of our more ill younger patients, obstetrical patients, patients with problems as simple as asthma. So it's important to realize that it's not just the sickest of the sick. Those individuals who have those risk factors should get in contact with their providers and get tested and be seen and evaluated to determine if you're a candidate for that. As Adam said, those numbers are staggeringly good when we look at how effective that is and what we want, which is preventing severe illness. No different than the vaccine. The vaccine prevents severe illness, reduces hospitalizations, ICU admissions, intubations, and death. Similar to that with the monoclonal antibody, what it does is it turns around that illness much more quickly. Those patients that are caught in the first few days of their illness that get treated report to us that they see symptom improvement within 24 hours, which is absolutely remarkable. There's hardly any other disease process that we have seen that with where there's a treatment that's so effective.
Yeah, it really has been astounding results. I think as we look, though, at the monoclonal antibody as a treatment versus vaccination as a preventative medicine, and we've seen some states, unfortunately, have kind of went the route of treatment versus even looking at vaccination and really advocating for vaccination. But what we don't know is those individuals that test positive, get sick, are at high risk with COVID, and then do get monoclonal antibody treatment and turn around and have better. We still don't know what the long-term effects of having the virus, allowing it to the viral load to increase to a point that they're at risk for hospitalization, whereas we know the vaccine is going to help prevent that level of infection occurring and those long-term outcomes, which are still an unknown, but certainly preventative and is the mechanism that we go against viral infections rather than just looking from a treatment standpoint.
Yeah, absolutely. One thing I think is worth talking about, I've gotten embroiled in a variety of social media, let's call them discussions, with individuals who continue to proclaim this vaccine does not work, the illness continues to spread, this was supposed to stop the spread of the illness, shut everything down. But the thing that we go back to, and I think that we all take comfort in, is the outcomes-based data that we see proves that it's done exactly what it's supposed to. And that brings up this term that sometimes people get confused of, which is this has become a pandemic of the unvaccinated. We see that a lot, and I think people don't quite understand what that means. Can we talk a little bit about that?
Yeah, and first off, we follow the data, and so if you just simply don't believe the data, believe that it's fabricated, I mean, that's a totally different conversation. Yep. The data that is out there with hospitalizations, with breakthrough infections, with death, and what we're seeing, I mean, that's being reported by the hospitals that care for this country on an everyday basis, and it's really never came into question, and it's kind of sad that it is today even coming into question, because the medical professionals have put their lives into this, their education, their training, and no different than you trust the auto mechanic to take care of your car that's went through training. Yep. You need to trust the medical professionals that this is what they do and are experienced in that. So I'll get off of that and talk about the reason it's considered the pandemic of the unvaccinated is because that's what hospitals to a high degree, 90%, 92% are full with. And when we talk about the vaccination status and vaccine versus unvaccinated, is that by and large, unvaccinated are the group that are at risk being hospitalized. Those are the largest percentage of deaths. Breakthrough infections of vaccinated individuals are extremely rare. And even to add another element to that, most breakthrough infections of a vaccinated individual are those that are immunocompromised and probably didn't have the vaccine response that an otherwise healthy individual would anyways. So you look at the data and it is just mind-boggling how you could think anything else. Right. I mean, we see the hospitalizations, we see the deaths, and then on the vaccine side, though we don't see those, but at a very small occurrence, because no vaccine's 100%. But these are showing tremendous results that stand up to really any other vaccine ever created in their efficacy. And while there are going to be breakthrough infections and it doesn't put that shield around you that you can't come in contact with the virus, vaccines were created for two reasons: to decrease hospitalization, to improve the quality of life, and basically return society to a normal function through allowing activities to open back up because the risk that was decreased through that. So preventing hospitalization and death, and they're doing that.
Yeah, unquestionable. And that's something that when I kind of try to break it down for people, we can discuss all kinds of data globally, locally, regionally. But what really interests us in medicine is outcomes-based data. What happened in the end? What happened at the end of the study? Well, the study that we're living every day is seeing those patients admitted to the hospital and what percentage of them are vaccinated or unvaccinated. And unquestionably, like you said, in some instances, 96, 98% ICU, intubated, so forth, are the unvaccinated. And interestingly, when we look at global data, because we always want to see like what's happening in other locations, big spike in Israel, big spike in the Middle East, locations like that. And although the numbers of people infected are relatively high, the numbers of people being admitted, it's almost the exact same reflection of our data. 67, 85% of people that are admitted in those hospitals and other locations, again, are the unvaccinated. We're very fortunate with our residency program here that we have people that are coming here to be trained as doctors from all around the world. I was having a discussion with one of our residents who's from overseas, had worked in a hospital in the UK. And in some of the socialized health systems around the world, if you come to the ER in one of those locations and you have a burn on your hand, the first thing you get is you get a vaccine in your arm. And so their vaccination rates are extremely high. And what that has shown is their numbers when the vaccine came out and was plentiful have been microscopic in terms of hospitalizations for that. So this individual was telling me basically that from coming from that situation over to ours and seeing the volume that we're dealing with is mind-blowing, because they're kind of already over that in that situation. Now, none of us are signing up for socialized medicine today or tomorrow, but that gives us some interesting reflection on other locations around the world with different health systems, with different resources, and how they've dealt with this.
And there was a really great article a couple of weeks ago. I think I sent you a kind of a snapshot of it, and it was a picture of a medical clinic in Africa, and there was a line as long as you could see, hours long line, and they line up every day hoping that there is vaccine at the clinic, and they give as many shots as they can, and then if you were too far in line, you have to try to come back the next day. And on the flip side of that, in a large city in the United States, in the southern part of the United States, was throwing vaccine away. And so that also, kind of, I'll give some kudos, and this is not a political view, but kudos to our administration from a government standpoint that they just pledged 500 million doses worldwide to be sent out. And that's where a lot of the discussion on the boosters has went, is we have to push towards a vaccination rate moving up before we look at vaccinated to booster. That unvaccinated is the bigger concern worldwide, because inevitably, if it's spreading and variants are emerging worldwide, they will come to the United States at some point, and then we start worrying about vaccine efficacy against new variants and all of those elements that come into play.
Yeah, and so that kind of brings us back to the discussion about boosters and what's it going to take to get back to whatever we consider normal. And ultimately, we believe, based on all other virology type things, that this will continue to decline and burn itself out and so forth. But the sooner that we can squelch the replication and new variants and so forth, the better. So I get asked on a nearly hourly basis about, what about a booster? Should I go get a booster today? Where do I get a booster? What's the story behind boosters? And talk a little bit about who can get them when, how that process is going to work, and thankfully you already answered the fact that thankfully it looks like supplies are going to be plentiful.
Right. Yeah, so first and foremost, supplies will be plentiful. As we look at boosters, right now the Advisory Committee Immunization Practice, the CDC's Advisory Board for Immunizations, is meeting. They meet today, they meet tomorrow. So coming tomorrow afternoon will be the final recommendation. Now, most that are following this online and through FDA alerts will see that an FDA panel did already make a recommendation for consideration, which is over the age of 65 and those at high risk for severe disease. What ACIP is now doing is looking at the over 65, which in almost all certainty will be approved. But then they're going to look at that high risk and start to put some detail to that. Healthcare workers, are they going to be high risk or not? Most are believing that they will be. Who else is in high risk? And we know immunocompromised is going to be high risk. Chronic diseases, and will they look to put some detail to that? We talked about those that are getting monoclonal antibody, obesity, hypertension, diabetes, heart disease, lung disease, probably all fit into that. But that's the detail that comes out tomorrow as a final, this is who is eligible for boosters. So the question of should I get a booster is going to start with, are you eligible? Right. And then if you are eligible, from an employee Good Samaritan standpoint, we're providing boosters to all of our eligible employees. Knox County Health Department is running their vaccination clinic. They have moved to a different platform, so the ourshot.in.gov does not list Knox County Health Department going forward. It does list other avenues, pharmacies in the community and such. Knox County Health Department's put out through their Facebook a website and phone number that can be called for that. I don't have those memorized yet because we've kind of switched gears with that, but they are still giving vaccines, so those are your access points. And then the other piece is greater than 6 months since original vaccination, so shot number 2, Pfizer, Moderna. For the Johnson & Johnson questions, they have not submitted to FDA yet for approval under emergency use for boosters, so that hasn't been evaluated. There's really no news to share on that at this point. But that's where we're at on boosters, and really tomorrow afternoon to tomorrow evening is when the final news gets released and says this is what the recommendation is.
Yeah, another thing that we've discussed a little bit that frequently comes up as a question is how soon after an illness can I get vaccinated? And really the answer is when fully recovered. There's all kinds of recommendations that float around out there, 2 weeks, 4 weeks, 6 weeks, 90 days, so forth. But really, as soon as somebody is fully recovered from the illness, meaning that they've their symptoms have resolved, then they're elected to have a vaccine at any point in time. we are hopeful that then becomes one of the most protected individuals around, which is I either had the illness and I got vaccinated, or I got vaccinated and then later had the illness. But those studies have been kind of interesting and compelling too, that have shown that those two groups of individuals are the most protected when we look at antibody protection. We love the thought that natural immunity is great. We love the thought that vaccine immunity is great. But really the two biggest groups that we're seeing that show the longest standing and most effective immunity are the had the illness, got vaccinated, got the vaccine, got the illness later on. So the vaccine is important regardless of whether you've had the illness or not. So we want people to understand that just because you had the illness, yes, natural immunity is fantastic and our own immune systems do great, but there's still benefit to that.
Yeah, that debate is probably going to continue to live on in the social media realm that I try to avoid.
Is there any way I can get you involved in those discussions? That'd be great.
I'll choose to let you handle those. But again, going back to the data, the science, infection plus vaccination is by far the most protected group. So that infection without vaccine is really not a discussion, because I mean, we're talking, if you're unvaccinated, you're at risk. If you're vaccinated, this is the protection that you have. It's not a no risk, but this is the protection that you have. So certainly, as we look at that, ending that kind of ongoing debate is past infection is really not a factor. It's not a criteria that we look at to say, should you get vaccinated or not. Now, I think it is easy for general public to become confused because elements of this have changed. Plus you have the elements of just misinformation. But as you mentioned, vaccination, as soon as you're recovered, as long as you're not quarantined or under isolation, you can get vaccinated. The only caveat to that is anybody that received our monoclonal antibody should wait 90 days post receiving that treatment, because it can impact the vaccine. It's not a safety issue, it's an efficacy issue, but that's really the only one. And as we come into an influenza season, the question has came up multiple times, well, I want to get the flu vaccine, I want to get COVID vaccine or COVID booster, I have to space those out, right? And that's actually not the recommendation any longer.
Yeah, really, co-administration of those is safe, and we would encourage that. It's obviously much more convenient for patients. There is no reason to separate those. Obviously, those of us that have children, children get 1, 2, 3, 4, sometimes 5 vaccines all at one time, and there has been shown, specifically with those childhood vaccines, a benefit to co-administration of some of those vaccines because it ramps up your immune system faster. I'm sure there will be ongoing data that we'll hopefully be privy to over the course of the next 6 months that says the same thing with regards to flu versus COVID. Other things you want to discuss before we go to the phones?
I don't believe so. Just make comment that from a hospital standpoint, our visitation restrictions remain the same that they have been. They're available on our website. We have gshvan.org. At the top is a yellow banner. It says coronavirus, shows our visitation, expectations, self-screening tools, all of those COVID-specific criteria from a hospital standpoint.
Okay. Tiffany's not with us today. It's is it Pam? Mallory. Oh, sorry, Mallory. Mallory's with us today. Go ahead.
There's many questions about the booster, so just if you want to reiterate that, we'll find out more.
Yes. So from a booster standpoint, tomorrow is the end of the ACIP meeting where the final recommendations will come out. It's anticipated to be over 65 and those at high risk. That's what really the meeting's going to focus in on, is who's high risk, what is that criteria, and greater than 6 months from initial vaccination. Just one plug that I will put in there as clarification on that, though. That is boosters for otherwise healthy individuals that the initial vaccination process was expected to provide, full vaccination or full protection. Third dose, third shot is eligible now for severely immunocompromised, think organ transplant, active chemo, cancer patients, high dose steroids on a daily basis. So those individuals are eligible now and ideally should get vaccinated with that third shot as soon as possible.
Okay, there's a couple of people that are interested in the number of employees that have been vaccinated and exemptions that have been approved in our organization.
So we have 61% of our employees that are vaccinated. That is actually up pretty significantly over the last 2 months. As most are already aware, we moved towards a mandatory vaccination requirement, very similar to our influenza annual requirement. Hundreds of thousands of healthcare workers had already moved there before. Now it is mandatory per the federal government. As far as exemptions, I don't really look at that as a specific how many exemptions. What we look at is how many are vaccinated and how many are not, because again, the reason doesn't really matter. It's who is vaccinated, who is not, and as more information comes out from Center for Medicaid and Medicare that are governing or the requirement from a federal standpoint for healthcare, just as they do for influenza, we'll get more data on kind of where those numbers need to be. As a frame of reference, hospitals across the country run 97, 98% influenza vaccination rates, and I'm sure the expectation for COVID is going to be that we move in that direction.
Yeah, and maybe part of what they were asking is what is an exemption, or what would be a typical exemption. I know personally I've signed for one individual to have an exemption who had had a previous vaccine for shingles and had Guillain-Barré syndrome as a result of that. So there are not really very many like strict criteria for exemptions. Obviously, the anaphylactic reactions with prior vaccinations. In this particular instance, a neurological consequence of a prior vaccination. But in my mind, those are some of the hard stops of, hey, this would be a reasonable individual. And we have this with other vaccinations where we say, hey, because of a previous reaction, this wouldn't be appropriate. But quite honestly, that's an extremely small percentage of people who have those type issues.
Right.
Have you seen any data about the long-term side effects of contracting COVID for those that have been vaccinated?
Yeah, so the interesting kind of question, and it's a sort of a two-part question in terms of what the long-term consequences are of contracting COVID, what the long-term consequences are of contracting COVID if you've been vaccinated. There's not a lot of data broken out on those yet, but the few case report studies that they're coming out with show that it's a reduced rate because probably of the severity of infection. Now, the long haul syndrome and some things like that have been described clinically. There's not a lot of understanding of why one individual versus another is more susceptible to that, be it something that's genetic, severity of illness. We don't fully understand that. But the case reports, and we always have to kind of look at case report studies somewhat carefully because those non-blinded type things don't help us as much as some of the data that we look at on blinded studies. But it's the best thing that we have as we go along, and no different than what we said 17 months ago or whenever this all started. The data is coming out literally every week, every month that we get to look at. And fortunately, we're in much better shape now in terms of that data on everything we're talking about than we were 6 months ago, 10 months ago, 12 months ago, 15 months ago. So that particular syndrome is not really well understood, but from what we can see so far, the vaccinated are less likely to have that in terms of long-term consequences. But again, stay tuned.
Okay. If one qualifies for a booster vaccine, do they need to get it from the booster from the same company that they got the original vaccine from?
So that's another piece of the recommendations that we expect to come out, but the guidance right now is that it should be the same. So if you had the Pfizer product as your original vaccination, that the booster would be Pfizer or Moderna to Moderna, and that is if possible. So if there is an availability issue, if there is some reason that you can't get the one that you had first, they are both mRNA vaccines. They're not interchangeable, but in exceptional situations that can be done.
Okay. Do you know of any updates on when children under 2 will be able to be vaccinated?
So we anticipate next month that children 5 to 11 will be approved for emergency use. That's been the FDA's focus, is to review that group predominantly because at 5 to 11, that group's still out in the community moving around, can be vectors for passing infections around. They do with all other viral infections that we talk about every year, as you see kids moving around the community. I mean, that's just something that we've come to know. Now, masks have certainly reduced that. But that underage population has been less of a focus. One, they're not as mobile, as we just said. I mean, they're kind of within their household, not in the school systems, those types of environments. And also, that changes more significantly the dose, the So it's not as much. 5 to 11 can be more of an add-on to the studies already performed for that 12 to 17 population, probably more in that 12 to 15 group. Whereas under the age of 5 is going to be different dose, different expectations, whole new trials that have to be evaluated.
Yeah, and thankfully, that population we are not seeing severe illness in,
Right.
thankfully. We see more issues with regards to RSV and influenza and things such as that in that population. But as Adam said, that will be studied. That will be something that will come out in the future. But really, as we kind of march down, that school-age population is the population we worry the most about because they are the vectors that are basically bringing that home and more easily spreading it within school systems. Although last year and this year also, as we've gotten further in the school year, the precautions the schools are using are paying dividends and working well.
Now, to go all the way even further back to age 0, there have been studies that have shown pregnant mothers that have been vaccinated that antibodies have passed over to their newborns, and so they have some natural antibody protection as they're being born. So as that vaccination rate of our pregnant women population or women childbearing age continues to increase, we're going to see some impact on the other end of that as well.
Right.
Okay, I'm not sure if you know the data for Knox County, but they're asking if they've seen an increase in vaccinations in Knox County and what % of our county is vaccinated.
Yes. 47%, just shy, I think it's 47.6, so just shy of 48% of Knox County is vaccinated. That data is based off of the eligible population, so 12 and older. So anyone under the age of 12 is taken out of that. And that's about a 10% increase from what we saw just 45, 50 days ago. So we are seeing that pick up. And ideally that'll continue to grow, but that's where we sit at now.
Okay. Are you aware of any studies out there about taste and smell? This person had COVID last December. Smell is not normal, it's just off.
Yeah,
Yes.
so this is a tough one. Many individuals, and it's interesting to kind of reflect back on where we were March, April, May, that this was fairly early recognized as an interesting or intriguing early symptom, and it has continued to play out throughout the illness, probably because of direct neurological effect on those receptors. But the unfortunate thing is there is a population, it is relatively small, that remains with fairly profound loss of taste and smell. The majority of individuals who experience that will regain that within a period of just a few weeks up to a month or two afterwards. However, what I have seen in my population, and there's a little bit of research that they're doing within the ENT study groups, that are showing that the people that about 3 months out that have not regained taste and smell are probably going to be in it for a while. Believe it or not, there is osmic rehab, which sounds pretty cool, but it is essentially no different than any other type of neurological rehab where you are taking a stimulus and trying to relearn those type phenomenons. This is available online to look into how this works, but the basic, quick, and easy understanding of it is you take things that are very strong smelling, very strong tasting, and you start reintroducing those into your diet, and there's a process to that in retraining those receptors. So no different than after somebody has had a Bell's palsy or a stroke or something of that sort. Those symptoms can be improved, and then once they reach a level of improvement, typically over a year or so, you got what you got. And that's what we're seeing so far.
I believe, is that parosmia?
Dysgeusia and parosmia and a whole variety of other terms that we don't use very often.
Actually, I had a conversation with a friend that is experiencing that, coming up on a year of loss of loss of smell. But a few months ago, that loss of smell came back, but wires crossed, came back. And in looking for some articles to help the individual out, raw sewage type of smell is one of the more predominant, like how it's came back. Like 25% of the individuals that have reported that their smell is off, that's an element of it. So, certainly there's some studies going on with that. There is not a treatment right now. There's not a medication. There's not a surgical treatment, because if you go out there and look, you may see that there's medication or surgery. Those are for non-viral infection related loss of smell. So yeah, we continue to look at that, and that's been a symptom of this all along that has just not been the normal viral infection that we see. And so I do think there will be more and more research towards that, as there's a higher number of individuals impacted long term, as you mentioned, greater than 3 months than what initially we suspected.
And with the Delta variant, I have seen, Dr. Mahan, a number of us that see lots of the COVID patients, the loss of taste and smell is not as predominant with this variant going around as what it was when we initially went through this last year. Certainly predominant symptoms we're seeing this year are nasal congestion and headache are two of the predominant symptoms. Loss of taste and smell is absolutely still on the list, but thankfully not as prominent as what it was with the first round.
Okay. This one says, my 3-year-old had COVID 3 weeks ago. It was rough for him since he has respiratory issues, but he has been coughing every day since. How long do symptoms linger?
So similar to respiratory syncytial virus with children, the actual acute phase of the illness is what we worry the most about, but the persisting symptoms, posterior nasal drainage, bronchitic type secretions, those types of things, unfortunately can last for a very long time. Very long time with RSV can be up to 1 to 2 years, which is a very long time. We have not seen that in the pediatric population lasting that long, but certainly within a few months is reasonable to experience that type of a symptom, as long as it's not associated with wheezing, difficulty staying hydrated, eating, so forth. It's not something that we generally suggest medicating. Several years ago, pediatric experts came out and said we really need to stop giving cough suppressants, mucolytics, things like that to the population under 6 years of age. And this is probably something that's close to your heart as a pharmacist. It's because we as parents are horrible at measuring medicine for children. Handing them the bottle, having them drink it, obviously terrible, but what 1 teaspoon versus 2 teaspoons versus, we're pretty bad at that. So we generally tell people not to use any type of medications in that category because they're sedating. They tend to make kids overly sleepy. They're easy to be overdosed with those type medications. So secretion management, if it's a wheezing type illness, sometimes falls back onto some of our respiratory medications, inhaled medications, nebulizer treatments. But in general, we do not encourage people that are having persistent symptoms like that to do, without being name brand on things, guaifenesin, dextromethorphan, diphenhydramine, those types of medications, simply because the studies that were done on those things showed that there were more negative consequences of treating the pediatric population under 6 years of age than not treating those symptoms.
Okay.
If you guys would just give us the little measuring spoon,
I know.
that would help a lot.
If and when OSHA releases the emergency temporary standard affecting businesses with more than 100 employees, how will the hospital or local medical network be able to support the additional testing requirements? Will they be able to keep up with the weekly testing demands?
Yeah, so we're having discussions around that very thing and setting up a process for what that will look like from a testing standpoint. We'd actually started going down that road before the announcement because some states had enacted that. Many healthcare organizations had already started to go that direction. Certainly from a healthcare standpoint, ensuring safety, so monitoring, surveilling for COVID is important on our behalf. Other employees or employers may view it as a lower risk scenario because they're not in healthcare where we are, actively bringing in COVID into our organization, and we have patients every day that are immunocompromised and at risk for infection should they get one. So we're setting up those processes. We're still waiting on the actual OSHA guidelines to make sure that we know the detail of what's expected. But weekly testing will be at a specified clinic of ours. We'll set that up for our employees to get notified the week prior of when they need to be tested. It will be a scheduled appointment that will be, this is when you get tested. It's impossible to do it as a walk-in and be a clinic of convenience. It's going to be clinic scheduled because that's really the only way that we'll be able to facilitate that. And then we have a community health team and our employee health team that's also reaching out to other employers in the region to say, how are you addressing this? How can we be of support from a standpoint of a healthcare professional, how to go about testing or perform the testing or all of those avenues. We're partnering with employers in the community.
And that will still be nasopharyngeal swab testing?
Yes, at this time.
Okay.
That's it for today.
All right. Anything else for today, Adam?
That's it.
All right. Thank you all very much for joining us. We'll be with you again in 1 week. be safe.